Well, hi, Dr. Geyer. Welcome back. This is so exciting. This is the fifth podcast in our series, and we're always so grateful and excited to have you with us today. We are going to talk again on the topic of opioid stewardship, and we'll be looking at opioid prescribing metrics our audience should be thinking about for their practices. And we'll cover some good communication strategies to help keep patients informed about changes. And I think that is so important that we really have that communication there with those that we serve. So, Dr. Geyer, would turn this over to you and just to get started.
Wonderful. Thank you, Marie. Well, we're going to talk about an exciting topic today. The topic of quality improvement and quality perception in this day and age, especially with all the regulatory oversight that's occurring, can't be overstated. So I'm excited to jump into this. I do want to preface it with this. None of us really like the concept of Big Brother looking over our shoulders. We know that, especially when it comes to the practice of medicine. But the reality is that historically, indiscriminate prescribing of the world's most addictive chemicals has really put us in the spotlight of all these regulatory agencies. They have reacted to us. And they are very committed to making sure that we are one less wild card to address when it comes to really curbing the opioid epidemic. So it's true, we're seeing a lot of regulation on this topic. We're seeing a lot of laws, a lot of third-party agencies, and all of these oversight principles that they have been the primary guide for us in the medical profession to help design the dashboards, the workflows, the protocols that we have, and ultimately how we'll identify whether or not we're meeting the needs of the patient when it comes to prescribing. Some that come to mind, your local Department of Health, right? The Joint Commission, CMS, we've even got insurance companies in there and other groups. So I will say I'm familiar with a lot of suggested dashboard metrics that have been released over the past couple of years by various entities. None really even come close to the accuracy or the comprehensiveness that's been made available through the AHA Stem the Tide Opioid Stewardship Measurement Implementation Guide. It's a very long word, but it's worth reading because it's got so many tools in there, Marie. So I vote that as we talk today, we really use this as our grounding wire for what stewardship really looks like.
Thank you, Dr. Geyer. We really appreciate that. And as a nurse who's been in quality for a really good portion of my career, all this is music to my ears. I think that the idea you mentioned of Big Brother looking over our shoulders, I really believe that as a field, and when we look over our own shoulders, right, nobody else has to do it for us. We're always looking to improve, to quality improvement and rapid cycle change, and really always looking to make things better. And if we're listening to the voice of the customer in all of that as we start, or the voice of those we serve, whatever your culture is, then we start out from the right place and we stay grounded in those things. And the spirit of transparency is so important as a field and in keeping the public trust engaged. And so really think this is an important topic for us to talk about. And we certainly appreciate your support and your interest in stemming the tide. It's really a great tool that AHA put together. So let's get started. Let's talk about the components that every program should consider monitoring and some of the communications around that.
Let's jump right in here, Marie. There's a lot of different ways to help develop metrics for any situation. And I've really liked the way that AHA has broken it down into two main groups. They've done it by patient population. the patient pain management population, and then the patient management of opioid use disorder populations. And because a lot of our discussion has really been around that opioid stewardship process and the management of opioids within a medical setting, I think we're probably going to focus more so for this podcast series on the pain management aspects today. But I do want everyone in our audience to know that AHA has actually identified a whole lot of metrics, not just for pain, but for opioid use disorder. So please check out the guide. So, I think we'll start by breaking down some of these hot topics from a regulatory standpoint. And a lot of this comes down to what's easiest to collect out of an EMR, what are you going to be potentially cited on, and what can you follow longitudinally that really impacts patient care. So, first thing I would really want to focus on, what does that prescription look like? And AHA suggests maybe looking at two key metrics. The first one is the average morphine milliequivalent per prescription. Great tool. Second one is the average morphine milliequivalent administered if you're in an inpatient setting per day. These numbers for outpatient and inpatient environments really give us a nice idea of whether or not we're practicing within CDC guidelines, institutional protocols, and best available evidence in the literature. Keep in mind, you're going to want to keep your total prescriptions to less than 90 morphine milliequivalents per day. If you go above that, your patient's at risk for overdose. Some data suggests even 15 morphine milliequivalents per day, which is the number we use at Mayo. It's a really good benchmarking number, or a benchmarking number. So consider setting that. Next, you're going to want to try and examine just how comprehensive are you when addressing pain management. For instance, what percentage of your patients are receiving opioids as their only pain management option? Really, you're going to want multimodal therapy in any situation where there is acute or chronic pain. And so do a quick chart audit to see if opioids are alone on the mark or paired with another pain medication to give you this number. I can tell you we had recently completed an internal survey and data review here at Mayo Clinic, just on our campus. And I thought we were doing surprisingly well, but I was very shocked at the number of deficiencies where we could be doing better. So even if you have policies and procedures in place, this is a great opportunity to continue to review the data to optimize what you're doing. Also, you're going to want to look at the percentage of patients who have documentation of patient-defined comfort and functional goals, who've gotten education on pain management. In the real world, a quick workaround to this metric is to simply build the practice of assessing functional goals into every nursing visit, and then build pain management education into the standard process. Every patient who comes in with a pain indication and who will be receiving opioids gets a handout. We've built our handouts on this topic actually into the admission packet for our inpatients. So there's some great opportunities to just make this a standard part of your practice as opposed to trying to remember it every time. And then don't forget, Joint Commission is going to require pain reassessment within 60 minutes of receiving those pain meds. So you build in the standard protocols that meet these requirements to make it easy for you. After this, you're going to want to focus on metrics that deal with harm reduction for the patient. The big ones that I see on this topic include, first off, the percentage of patients with opioids and benzodiazepines or other sedatives on their chart. I can tell you there's at least 4 advisory and regulatory agencies that are really keeping an eye on this number. It's not hard to pull from most EMRs. And remember, the CDC has identified if you want co-prescribing to occur, you're putting your patient at high risk. So keep the numbers as low as possible for total patients receiving dual therapy. Number 2, the number of naloxone prescriptions written. We've talked about this in depth already in other podcasts. But again, if your patient has triggers for co-prescribing, things like chronic medical issues for baseline cardiopulmonary deficiency, high morphine milliequivalents per day, typically greater than 50, make sure that Narcan or naloxone is being prescribed. Number 3, the number of controlled substance agreements that are signed when chronically prescribing. Ideally, that number is going to be 100%. So check an audit, see where you're at. And then PDMP checks. That's the Prescription Drug Monitoring Program. Your state might already have this as a standard requirement, but just doing a quick comparison between the number of patients that are receiving an opioid prescription and the number of times a PDMP has been checked, those numbers should be about equal. And then finally, Marie, one thing I would say, if your practice does not engage in buprenorphine prescribing, one additional metric that you could consider looking at through just a quick audit is a management of number of referrals for opioid use disorder. Take a look at your EMR and see if these referrals are internal to your practice, how many times they're being ordered in the setting of opioid use disorder as an ICD-10. Alternatively, if you're referring out, maybe just do a quick audit of chart reviews to see, making sure that patients are getting access to treatment. You might be a little surprised at what you find. I've been a bit surprised myself with some of our internal audits.
Wow, Dr. Geyer, this is flashing me back to my quality days in a healthcare system where I used to work with the medical staff chairs and those folks that were leading programs like this and that helped them set up the metrics and the monitoring processes for their field and their areas. And I remember some of those conversations and how difficult it was for physicians leading these kinds of initiatives to manage all of that. Can you talk about some of your success stories or ideas or best practices that other folks can learn from and use about how to best pursue monitoring so that it's successful and really seen as a tool for improving care versus the burden of reporting that so often folks feel when they have to do these kinds of things?
I can tell you, Marie, one person is not enough. None of us are as successful at this as all of us. If you really want to do it right, you're going to want a team concept on this. And I will say that's going to be so helpful for running, deriving, creating quality improvement initiatives for all of these metrics. I would say without a doubt, IT, quality, legal, and compliance should be included in these discussions to begin with. They're going to give you a great understanding of what the regulatory environment looks like and where you're really going to want to tailor your metrics to. In addition to pulling out the AHA guide, which we have been discussing, you're also going to want to review your state statutes, see what laws are on the books that limit or regulate your prescribing practices. And then once you've got all these metrics in place, once you have an idea of what you want, ask your IT team which can be reliably gathered from the EMR. Go for low-hanging fruit. I would say, again, AHA was incredibly helpful when they built that guide and actually went so far as to define what the numerator and the denominators are actually going to be in calculating the more common equations that they recommend following. For metrics that can't be gathered in the EMR, maybe consider using a small part of the practice that's likely to engage in the activity that you want to monitor to create a QI project out of it. We've done this here at Mayo Clinic, and it's been very helpful in our family practice and CIM groups. It might also involve a little bit of manual labor, try and chart review an estimate of current state, and then develop those QI initiatives for following up and developing interventions that might be helpful to other areas of the practice. We have found that building these metrics into dashboards is the easiest way to track compliance and improvements. Like I mentioned, we use Epic, and that's been a very useful tool for building dashboards for us. I would recommend the development of two separate dashboard systems. So first is those available to the individual prescriber, and then the second one is those that's available to the division as well as the Opioid Stewardship Program leadership. For individual prescribers, their dashboards might have content on the topics most likely to impact their behaviors. And there's logic to this, right? So if you're in primary care and there's a host of other metrics that you're already trying to follow, make the ones that are most simplistic and the ones that change day by day stewardship activities easy. You don't want anything unnecessary that's going to be the straw that breaks the camel's back on this. I can tell you for our institution, what we thought to include is the opioid prescription exceeding more than 90 morphine milliequivalents, the average number of morphine milliequivalents per prescription, the percent of prescriptions where benzodiazepines or sleepers, sedatives, and opioids are all being co-prescribed, the number of naloxone prescriptions for more than 90 morphine equivalents opioid prescriptions, and the percent of opioid prescriptions where the PDMP is checked. We also have a little micro dashboard for people that are engaged in chronic opioid prescribing so they can monitor, the things like urine drug screens or the number of individuals or percent of individuals that have a signed opioid agreement on the chart. The remaining items, and these can be the ones that AHA has added onto the list. Like I mentioned, there's more than 30 of them. You can build into the leadership dashboards and have the ability to look not just at individual prescribers, but more at a division, department, and even enterprise or at least individual institution level. That way you can handle larger QI projects that impact all providers if you're defining deficiencies.
That's really good suggestions, really good advice, Dr. Geyer. I think that when I think about this, right, we always think about what an individual does versus what the system does and how you roll those things up so that you see the different levels. So you see the 30,000-foot view, and then it rolls down and you see the specifics. And it's so important to remember structure, process, and outcome, right? What is the structure? What are the things in an organization that need to be in place to be successful? What are the processes you have to follow related to that in order to drive to the outcome that you want to get? And frequently, we may not have all those structural pieces that we need, and maybe we need to improve processes. So I think these dashboards and the way you've laid this out can really be helpful in getting us to be successful. And the one other thing that I would say is for folks not to forget to celebrate the successes. Sometimes we hear dashboards and we think negatively about those, or we think that they're, trying to point out our faults. But I think they're also extremely useful in showing how successful practitioners are being in the care they're providing to those we serve. And so one of the things that, from my background and experience, was also getting the board involved and getting the CEO to allow you to share information with the board, and sharing some of the rolled up dashboards with the board, and getting their support and engagement as well. So you've got a great plan. I'm glad that the AHA tools were helpful. And I really encourage folks to be positive about this. Think about it as a real tool for success. And don't forget to celebrate those successes with your team. We know that people do such amazing work and work so hard at this, and we want to make sure that celebration is included in that and everybody feels good about the work being done.
Really good points, Marie. I'll tell you, if you tell your staff that the beatings will continue until morale improves, you're not going to get the way you want. So I agree with
That's right. Yeah.
The small wins can be big.
That's right. Exactly. And we none of us can hear too frequently how things are going well versus hearing the negative. So that's really great. So we do know that things don't always work the way we want them to. And can you talk a little bit about how institutions might intervene if a particular provider or group of providers or division within an organization seem kind of out of line with expectations? What would be the steps that you might follow, or can you talk a little bit about that philosophy?
Yeah, we're touching on a topic, Marie, here that has been a difficult one to manage through COVID. We see the burnout rates amongst our providers, our clinical staff. We know that things have changed so much. And when I talked about a straw breaking the camel's back, the data shows that we're there. This is all the more reason to make sure that, just like you said, celebrate the small wins, and that when there are changes that need to take place, we move from a state of problem creation to solution finding as a mentality. And that requires collective buy-in. That's an we're all in this together mentality. So with that, penalization becomes more of a less appealing approach to partnership. And that's where I really want to take this conversation. You're going to want to partner. For many of these important metrics, there is wiggle room just by field of practice. Trust me, the last thing you're going to want to do is pull up the palliative care leadership dashboard on opioids and then penalize them for writing too many prescriptions, more than 90 morphine mill equivalents, right? I mean, half their patients, this might be the last prescription they ever receive for legit reasons. Similarly, you're going to have a very different expectation for prescribers, in family practice versus thoracic surgery practice that do pectus excavatum revisions. All things are not created equal in the world of medicine. So allow room for individualization. I would say a good place to start might be looking for internal deviations within any particular division or practice setting. Who are the outliers? Are they outlier patients, or are they outlier prescribers? In situations where certain divisions or providers really seem to be out of line with dashboard expectations, inquire and inspire. And I'm going to say that again, inquire and inspire. This means find out why. Is there literature to support their prescribing approach as standard of care? Do they really follow what's best in their industry? And if so, make sure that you've accounted for that when you're looking at these dashboards. That is especially important for very specific patient populations, particularly those in the surgical industry. Find out if the answer is yes, and then consider setting maybe small but targetable objectives. Maybe a 10% reduction in morphine mill equivalents is something that's pretty realistic to accomplish over the next 3 months. And keep in mind, again, pair every intervention with other counter metrics, refill rates, number of angry phone calls coming into a practice. For every action, there is an equal and probably very opposite reaction. So keep an eye on both. Something else, if it looks like the division or the provider is simply not engaging in opioid stewardship to the degree that's expected, a good example being, nobody's checking PDMP or prescription drug monitoring program, then lean on the opioid stewardship team to have a meeting with division leadership on prescribing expectations and just re-educate. There's always areas for improvement no matter what we're doing. And if that's the case, then people are pretty far off. You're going to want group engagement, and it's probably going to be more of a top-down leadership-led support effort. Lean on leaders to be that voice of reason. Keep in mind, Marie, I got to say this, it takes time and it takes trust. Lean on the why. Make them internally motivated to do this on their own. Sell these concepts. I can tell you, there's not a provider worthy of their medical degree who wants to see some 16-year-old overdose because we as a practice overprescribed opioids. There were leftovers in a closet. They found them. That's not within our DNA. And so I would say the opioid stewardship program is there to support the prescriber so that the prescriber can support the patient. Again, it all comes down to partnership.
I love that inquire and inspire. And it seems to me that as we do that, we really drive to looking back at, the basics of quality, and that is looking at structure, process, and outcome. If we don't give our providers what they need in order to do that job, and then really inquire and inspire them. And I think that is so critical. And I might just have to borrow that inquire and inspire from you going forward. I love it. That's really great. So let's pivot a little bit. And you and I talked about this briefly and almost, I guess almost it's been a thread in the podcasts we've done together. But I want to talk a little bit about another key stakeholder in the opioid stewardship process, and that is really the patients and those receiving the service and the care that we provide. We've looked a lot at how to share the practice with leadership and prescribers. We've talked about the C-suite and the board a bit, but let's really get to the heart of this, and those are our patients. How do you suggest really messaging this to the patients, and describe any tools that you've come up with or used to help get that message across? Because really, as we've talked before, this is all about what matters, and it's so important to be able to provide compassionate care to those that we serve. So give us some insights and thoughts around this idea of communicating with the patient.
Maria, I have to say, I saw a demotivational poster once. No, those are anti-motivational posters. It said customer disservice because we're not satisfied till you're not satisfied.
Oh boy. Yeah.
It's a tongue-in-cheek reminder of what we don't want to transform.
What we don't want. Yeah.
No,
sometimes that helps make what we want clear. So yeah, I love that. Okay.
The logic to that poster is that, you don't want this one-sided interventional arm with no input from the end user. And again, I go back to the word partnership for it. The reality is that the data is showing there is almost an equal number of patients out there that are scared to death of using opioids due to these side effects that are, well brought out in the literature, well brought out on news media, well brought out from friends and family, as there are from individuals actually dependent on them. So we've got the scared people, we've got the people that end up with complications. How do we balance this messaging? The goal with the opioid stewardship program is not to tell patients they are unsafe. Opioids are not the enemy. Rather, what we want to change our messaging to is that they are safe when they're used in the right patient, for the right indication, with the right drug, at the right dose, for the right length of treatment. I can't overemphasize that concept enough. I truly believe when patients know that we've gone the extra mile to screen them, when we've put them first, when we've monitored parameters that help prevent complications, it all comes with an inherent understanding that we are proactively preventing unwanted consequences that they don't want. In my view, hands down, the best way to get this message across is to start with the very first step of establishing that opioid stewardship program. And any listener who's made it this far in the podcast series is clearly committed to that concept already. So we're heading in the right direction. Within the opioid stewardship program, I recommend developing a comprehensive patient communication plan on these changes. I will say at our institution, this was an evolving process. And I'm making this comment out of hindsight, not out of foresight, because I really didn't predict well when I helped start ours what we would have encountered from a patient response standpoint. We learned, first thing, a patient announcement as to why you're making changes is going to be so key. There were so many regulatory changes, so many different requirements from a state law standpoint that came out that our patients were very confused and many were very upset. Have a document in place as to why these changes have been in place and include the why if there's been rising death rates. The state laws are driving some of these decisions. We found internal quality metrics that showed we could be improving. The data doesn't necessarily show that opioids help in every situation anyway. Put all of that in to that document and make sure your patients have easy access to it. Next thing I would do, make sure you have a handout for acute prescribing. We developed one internally after we realized that patients just didn't understand what's involved with acute prescribing. Many of our patients thought they should take every single pill in that bottle. Many patients had received much longer courses of opioids than necessary and were putting the rest in medicine cabinets. Many didn't recognize that they couldn't get 3 refills after a first refill because it's developing into chronic opioid use as opposed to acute. Having that document handy really saved more hours for us in our inpatient and outpatient settings because patients could now read it in a standardized format. This helped alleviate frustrations and really helped standardize content that they got. And in many respects, it put the frustration of the shoulders back on the institution and the state or regulatory officials, as opposed to saying it was just me as a provider who made the decision. Another tool is to build in expectations early. For hospitalizations, consider creating a video or showing one on safe opioid management and in-hospital pain control. We did both of these. Patients are required to watch these videos when they first arrive, and I think it's been really helpful to have built reading material on the same topics. Like I mentioned before, we put a lot of this information into our admission packets. For the outpatient environment, videos that can be pushed through a patient portal if you have that capability, handouts on acute pain management or safe opioid management or safe opioid storage, all built into your prescribing practices can be great. And then finally, please consider having legal assist in drafting documents that'll be sent to patients on the topic of transitioning chronic opioid therapy to a different provider. We ran into that as an institution as well as, many practices are terminating opioid prescribing for certain reasons, moving it over to family medicine or chronic pain management. Make sure patients understand the why and the how and make sure there is a safe plan for that transition. I found legal very helpful in designing those documents and those conversations.
Good advice, Dr. Geyer. Absolutely good advice. And we've talked now periodically about this idea of balance, right? And kind of balancing measures. And you do one thing and it has either anticipated or unanticipated consequences. And so, how do you balance those things? And one of those perspectives when it comes to patient perspective is this idea that we're all familiar with, and that's using patient satisfaction scores. So can you talk a little bit about patient satisfaction in this area of opioid stewardship?
Gosh, Marie, I wish we could tackle a simpler topic because this one hasn't been easy. We all know patient satisfaction as a metric driver can be a double-edged sword, and especially on the topic of opioid stewardship. As we had talked last time, meeting patient expectations can come at the cost of patient safety. Likewise, if interventions are too rigid or not integrated in more of a partnership manner with the patient, you lose your customer base. So, where is that fine line and how do we walk it? I can tell you the most important point that I could emphasize on this topic is that these interventions are strictly for the patient, not against them. And I'm going to say that again, they're for the patient, not against them. Tell your patients this. When you can sell the why, and I will say the media has done a pretty good job of doing this already with the epidemic, patients start to realize that you're all on the same team. These changes, these rules are not against them, they're for safety. And so I'm going to tell our listeners that establishing a program is unlikely to, I'm sorry, I'm not going to tell our listeners that establishing a program is unlikely to impact satisfaction scores. I will tell you that they'll keep their patients alive. And I believe that if you integrate all of these with compassion and education and reinforcement and a partnership attitude homogeneously through the practice in a very standardized format, you can minimize damages in this area.
I completely agree with you. And I think that the other thing that I would just throw out there as something is that the consistency of messaging across our continuum of care has got to be really important. And I think in this case, if the patient or if the receiver of care is hearing the same messaging across providers, that has to help, because then they know that that message is consistent and is a source of truth for how their care is provided. So I would think that would be helpful as well. And the more work we do along the continuum in that direction probably would also help that satisfaction that we all struggle with at times.
Absolutely.
Well, thanks, Dr. Geyer. That's really awesome. We've had some amazing discussions, you and I here. I hope that our members feel the same, and the folks listening. It feels like we've been drinking from a fire hose, and I'm sure that if I feel that way, others feel that way. But the topic couldn't be more important. It couldn't be more relevant, more timely. Could you take a few minutes to share with the audience some of the best resources for them to turn to if they're really interested in building or augmenting or drilling down and going deeper in some of these areas and working on their own opioid stewardship program?
Yeah. And, in tandem to what you were mentioning about having standardized conversations, standardized messaging across an institution or an enterprise, I can tell you, Marie, I live in the Phoenix Valley and we've got at least 5 major large healthcare systems here. There is a deficiency in, similarities between practice, even between the healthcare institutions. This is why I'm so appreciative with the Stem the Tide toolkit. What you guys have done is really build us more of a standardized national approach to how we handle all of this. And I would say if every institution integrated the concepts that you guys have so well provided, America would look very different. So in addition to that toolkit, there's a couple other main resources that I would recommend every institution have in their back pocket to go to. The first is going to be those 2016 CDC guidelines for chronic opioid prescribing. Again, we're very much looking forward to the updates, which are coming soon. I would say the document is huge. It covers a whole lot more than chronic prescribing, but it comes with the evidence base as to the decisions. And that sometimes can be very helpful for developing talking points with patients. It's worth a read. Bring a large cup of coffee. We've already talked about that Stem the Tide toolkit and measurement implementation guide that was built by the AHA. Please do not leave this podcast series without downloading that today. It's really the framework for designing a program, awesome resource links, and expands far beyond what we've been able to cover in just this short podcast series. I'd also turn our audience's attention to 2 societies, the American Academy of Pain Medicine and the American Society of Addiction Medicine. Please go through their websites and you're going to find a wealth of information on how to treat pain, how to treat addiction, tools for every level of practice. From an inpatient environment standpoint, the Society of Hospital Medicine website has a guidance statement on opioid prescribing for hospitalized patients. Very helpful, especially for me as a hospitalist. I've helped design internal protocols for us based off those. We didn't cover a whole lot of inpatient administration guidelines, but it's worth the read. And another group, I'd preface this statement by acknowledging I don't treat pediatric populations, but please consider relying on your pediatric experts to design opioid guidelines as well. The brain exposure to opioids at a young age has tremendous changes over time in comparison to adult exposure, much higher risk for development of opioid use disorder over time. So I know JAMA had a great article on opioid prescribing in children after surgery. There's a host of other references out there as well, but please do individualize for that population. And then finally, for palliative and cancer populations, please consider using the 2016 Journal of Clinical Oncology recommendations for safe opioid use. If you've got hematology patients, and particularly those with malignancy, there's a 2020 blood publication that I was pleased to collaborate on as well. And that's got some great tools on how to standardize approach to management with opioids.
I think this is such important information, Dr. Geyer. Thank you so much for your time, for all of the work that you do on this important topic, and for being willing to share this with the American Hospital Association and all of those that are in our audience and participating. This is just so important. And the American Hospital Association is committed to all of you and your ongoing education as we navigate the opioid epidemic. We really hope you stay tuned for more educational updates on this area of opioid prescribing and management of opioid use disorder, including the recent expansion of MAT prescribing rights to all providers with a DEA number. Love to hear from you if you have a topic or an area in the opioid work that you are interested in hearing more about. And I would be happy to share. My email is mfishman, Fishman, @aha.org. And if you have a suggestion, please feel free to send that to me. I would be happy to look at working on that in the future. We want to continue our work here. Dr. Geyer is an amazing practitioner who's been so willing to share her knowledge and her thoughts, and her work is so very thoughtful and really centered on those that we're treating and that we're providing service to. She's available for questions, and she has so generously provided her contact information at the Mayo Clinic, which is 480-301-8000. And she's such a valuable resource in this area. So thank you all for listening in, and safe prescribing to all.
Thank you, Marie. What an opportunity, and glad to be partnering with AHA and all of our members out there to engage with opioid stewardship. Keep doing the amazing job you're doing.